Hello and welcome to the fourth presentation of the medical track of our small animal vaccination symposium, Vaccination Unites Us. For those just joining, my name is David Sutton. I'm the Global Technical Director responsible for small animal vaccines at MSD Animal Health, and I'm the host for the medical track of this symposium. It's my immense pleasure to welcome all our global delegates to this educational event on vaccination and vaccine-preventable infectious diseases. Thus far, we've had presentations on vaccination guidelines, canine leptospirosis, and feline leukemia. Now we're going to switch back again to dogs and talk about a disease which is probably one of the most familiar and globally widespread of the vaccine-preventable canine diseases. Canine parvovirosis. This is a disease which is still frequently seen worldwide, not only in stray dog kennels and shelters, but even amongst owned, cared-for dogs. It's still relatively common, certainly compared to many of the other diseases we routinely vaccinate against. The fact that this is one of the core diseases which all dogs should be vaccinated against, and yet is still frequently seen, is one of the enigmas of canine parvovirosis. Why should this be? Well, to help answer this and also address many other questions about the virus, treatment of the disease, and how best to protect against canine parvovirosis, we're both privileged and delighted to have Dr. Mary Marcondes to talk today. The title of her presentation is What's New in Parvo? An update on prevalence, treatment, and best protection practices. Before introducing Dr. Marcondes and asking her to give her presentation, I have a couple of quick housekeeping items to remind you of. Firstly, as you'll see in a moment, Dr. Marcondes is very familiar with the current scientific literature on canine parvovirus and cites many of the most important publications in her presentation. In order to avoid you having to take down details of all of these, full details of all the references will be emailed to you after the event. Secondly, should you experience any technical problems, please use the contact information listed at the bottom of the webpage. So, without further ado, I'm delighted to introduce our next speaker, Dr. Mary Marcondes. Dr. Marcondes is a veterinary surgeon with over 95 scientific papers, 18 book chapters, and 350 lectures on vaccination and infectious diseases to her name. She was a professor at Sao Paulo State University for 26 years, where she focused on small animal internal medicine and infectious diseases, which continue to be her areas of research and education interest today. She is currently a member of the WSAVA's Vaccination Guidelines Group, a member of the African Small Companion Animal Network, AFSCAN board, and a member of the Companion Vector-Borne Diseases, CVBD, World Forum. Please join me in welcoming Dr. Marcondes, and I'd like to invite her to give her presentation.
Thank you, David, for the introduction. First of all, I would like to thank MSD for inviting me to talk to you about Parvo at the Vaccination Unites Us Symposium. The idea of this lecture is to update you on the prevalence, diagnosis, treatment, and prevention of the disease. Canine parvovirus was first isolated in 1978 after an outbreak of dogs with enteric disease in the US. It was named CPV2 because it was the second parvovirus described in dogs. Between 1979 and 1982, CPV2 was replaced by a new strain, CPV2A. the virus quickly mutated again, and the new strain CPV2B emerged in 1984. Finally, CPV2C was first reported in Italy in 2000, but a study published by Dr. Nicola De Caro in 2007 showed that CPV2C had been circulating in Germany 4 years before its first detection in Italy. CPV has a tropism for rapidly dividing cells. When the first cases of parvovirus infection emerged, before widespread vaccination of dogs, myocarditis was common in puppies. This used to happen because puppies lack maternal antibodies and the virus infected dividing myocardial cells. There are studies suggesting that CPV remains a cause of myocardial damage in dogs, but the fact is that cardiac problems due to CPV are rarely seen today. Nowadays, puppies tend to become infected when maternal antibodies decrease, that is, after 6 weeks of age. At this age, rapidly dividing cells are found in higher proportion in gastrointestinal tract, lymphoid tissues, and bone marrow. Young puppies from 6 weeks to 6 months, but especially those less than 12 weeks of age, are more likely to develop severe disease. However, we can find unvaccinated or improperly vaccinated adult dogs with parvo. The frequencies of CPV variants differ between countries, and the distribution is not static. In this review published in 2016, the authors showed the worldwide distribution of CPV2 variants. Although this map is probably outdated, I included it just to give you an idea of what happens. In red, we have countries with CPV2A, in pink with 2B, and in green with 2C. Although the UK here is highlighted in green, there is just a study from 2007 that found one 2C sample out of 41 tested, but no 2C has been identified since then, as far as we know. Just as an example of how predominant variants can change over time, we can look at the molecular surveillance in Australia. Between 1980 and 2005, there was a clear predominance of CPV2A, 95% of the cases. From 2007 to 2016, CPV2A comprised 53% of the cases, and 2B 46%. And a study published in 2020 showed that CPV2B has emerged for the first time as the dominant variant. In this study, CPV2 sequences identified were most likely vaccine viruses. In this article, the authors tracked the evolution of CPV2 and found that CPV2C shows a tendency to replace 2A as the new dominant variant in South America, North America, Asia, and Africa. And this can be observed in many publications around the world. I just included here some examples. Because of this predominance of CPV2C in many countries, the question was raised, is this strain more pathogenic? There are not so many papers published, but it doesn't appear that CPV2C is more pathogenic. Let's talk a little bit about diagnosis. How can we diagnose parvo? Patients' age and vaccination status associated with the presence of clinical signs of parvoenteritis plus laboratory abnormalities can be supportive but not confirm CPV infection. Several methods are currently available for the diagnosis, including point-of-care fecal antigen tests, fecal PCR panels, hemagglutination, and virus isolation. Although PCR is the most sensitive, representing the reference standard, the most widely used tests for the initial screening and diagnosis of Parvo are point-of-care fecal antigen tests. Several point-of-care tests are commercially available. This study was published in 2021, and they evaluated 8 point-of-care tests in comparison with qPCR in fecal samples from 150 dogs. Specificity and positive predictive value were 100% in all tests, so there were no false positive results. However, the sensitivity varied from 32 to 49% in the group of dogs with enteritis. This means that false negative results varied from 51 to 67%, depending on the test. False negative results can occur depending on the time of the testing, the virus load, and high titers of antibodies that can bind to viral antigen in the feces and block their reaction with antibodies in the assay. And of course, with the quality of point-of-care tests. Experimental studies showed that CPV shedding started 3 to 4 days after inoculation, with the highest virus shedding between 4 to 7 days. So depending on the result, you can retest this dog or perform fecal PCR. Sometimes vets are concerned regarding the ability of point-of-care tests to detect CPV2C with the same accuracy as CPV2A and 2B. There are studies that evaluated different point-of-care tests and showed that CPV2C can be detected with the same accuracy as other variants. And does vaccination interfere with point-of-care results? We have to remember that if a dog is vaccinated with a modified live virus vaccine, this virus will replicate and there will be fecal shedding. The exact duration of the fecal shedding after vaccination is not known. In some studies, shedding was detected from 12 to 28 days by PCR, depending on the vaccine. Most of the time, a fecal antigen test will be negative, since the cutoff is usually high enough to not pick up vaccine shedding. But this can happen, so we need to be careful when we are testing a dog that was vaccinated in the previous 4 weeks. This issue is most relevant for puppies receiving their primary course of vaccinations, since during vaccination protocol, they can be susceptible to CPV infection. Let's talk a little bit about PCR. Do we need to run PCR when we suspect of Parvo and have a negative point-of-care result? Is it going to change your treatment? The answer to both questions is no. From a clinical point of view, if you have a dog with clinical signs of CPV enteritis, you are not going to change the treatment based on PCR results. However, if the dog has been properly vaccinated, you may need to use PCR to confirm if this is a lack of vaccine efficacy. We must also remember that PCR has a higher sensitivity compared to fecal antigen tests, and it can amplify CPV from modified live vaccines in feces. In this situation, quantification of virus load in feces using real-time PCR can help us interpret a positive PCR result. And what about treatment? Well, some of the therapies that will be mentioned here may not be available or licensed to be used in dogs in all countries. So before using, please verify that the medication is licensed or available in your country to be used off-label in dogs. Fluid therapy is one of the most critical aspects of the treatment. Whenever possible, fluid should be given intravenously and supplemented as needed with potassium chloride and dextrose. We usually don't recommend administration of subcutaneous fluids for puppies that are vomiting or dehydrated. However, sometimes it is necessary when client financials do not permit treatment in hospital. Patients with Parvo are at high risk of bacterial translocation with bacteremia and sepsis. If we believe that this is happening, we need to use antimicrobial drugs. We have many different choices. Injectable cefoxitin alone may be sufficient for many dogs, but puppies that have evidence of sepsis should probably be treated with a combination of a quinolone, such as enrofloxacin, and ampicillin or metronidazole. The use of fluoroquinolones in young animals has been associated with cartilage damage, but when we use them for short periods of time, such as for treatment of Parvo, I would not be concerned. One important point is that if the dog is well enough to eat, it probably doesn't need antibiotics anymore. Once the enterocytes are regenerating, it's unlikely that they will have bacteremia. So if the dog was hospitalized and is now eating and able to go home, there is no need to maintain antibiotic treatment. When we send this dog home, an option could be the use of probiotics. There's a recent paper published in 2019 showing that parvoenteritis was associated with significant microbial dysbiosis of the intestinal microbiota. The use of antiemetics is important to decrease vomiting. In this study, they compared the use of metoclopramide, ondansetron, and maropitant in dogs with Parvo and showed that all antiemetics were equally successful at reducing vomiting. Enteral nutrition is essential to help prevent enterocyte atrophy and to provide nutrients required for healing. The sooner we start to feed our patients, the sooner they will recover. This study showed that early enteral nutrition with a nasogastric feeding tube was associated with decreased patient morbidity and decreased length of hospital stay as compared to withholding food until vomiting has stopped. Dogs with Parvo usually have significant hypoproteinemia, and patient morbidity and mortality can increase when serum albumin concentration decreases to less than 2 grams per deciliter. So albumin can be restored by administration of either fresh or fresh frozen plasma or concentrated albumin products. We have also synthetic colloids that can be administered. Treatment of puppies with recombinant feline interferon omega has been associated with reduced disease severity and in some studies reduced mortality. The problem is that we don't have those products in every country. It needs to be used off-label, and it can be extremely expensive. We have few studies evaluating passive immunotherapy. but some of them lack statistical power, and the results were not enough to prove the efficacy of those products. There's an article published in 2020 from Colorado State University evaluating a commercial hyperimmune plasma, which concluded that dogs with Parvo that received HIP within the first 6 hours of hospitalization demonstrated improved markers of shock during the first 24 hours. However, depending on the client, there are less expensive options, such as the use of serum or plasma collected from a hyperimmune dog, that is, a dog that was properly vaccinated or that survived from parvoenteritis. Other treatment that has been investigated is the use of recombinant granulocyte colony stimulating factor. But there is no sufficient evidence to say that we should receiving standard treatment and the other receiving standard treatment and fecal transplantation. In the first 48 hours of hospitalization, there was a marked difference in the resolution of diarrhea with fecal transplantation. It was associated with faster resolution of diarrhea and shorter hospitalization times when compared with standard treatment. The mechanism of how fecal transplantation resolves clinical signs in dogs with Parvo is probably because the diarrhea is perpetuated by bacterial dysbiosis. One of the primary challenges and limiting factors for owners in the treatment of Parvo is the cost of hospitalization and treatment. In this study, the authors compared 2 treatment protocols, standard in-hospital versus modified outpatient. And they wanted to find out if the protocols affected the duration of treatment, the survival of drugs with Parvo. The survival rate was 90% for the inpatient and 80% for the outpatient group, with no significant statistical difference. Of course, 90% is better than 80%, but outpatient care may be considered when owners cannot afford to pay for hospitalization. Let's talk about prevention. Vaccination is the most effective measure to control the spread of CPV infection and to prevent the development of the disease. Vaccines against CPV are considered core, which means that every single dog should receive. Most of the vaccines against CPV are modified live vaccines. Although in some parts of the world we have also inactivated or killed vaccines against CPV, we don't recommend their use when modified live vaccines are available. But a modified live vaccine contains live but attenuated viruses that can infect cells and replicate within them, establishing a low level and transient infection that produces a strong immune response without causing disease. They typically require fewer doses to achieve a strong immune response when we compare to other types of vaccines. CPV-modified live vaccines generate a long-lasting immune response that lasts for many years when they are given to a puppy in the absence of maternally derived antibodies. CPV variants that are included in modified live vaccines are the original CPV2 and CPV2B strains. Recently, recombinant DNA technology has been used to produce a novel live recombinant vaccine against CPV. The CPV component is combined with a more conventional modified live distemper virus. This vaccine is intended to protect puppies against CPV infection at a very young age, at 4 weeks, by breaking through maternal-derived antibodies more effectively than previous generation vaccines. This vaccine contains a recombinant chimeric parvoviral genome, part CPV2C and part CPV2. The recombinant genome is used to produce live parvovirus that can infect cells and multiply in vaccinated puppies just like a conventional modified live vaccine. But the problem is that not every single vaccinated dog develops immunity against CPV. The main cause of vaccination failure is the presence of maternal antibodies, which can interfere with immune responses to vaccines. Some studies have reported the occurrence of parvovirus infection in vaccinated dogs. However, when we need them carefully, most of them, or almost all of them, don't mention the exact time when those puppies were last vaccinated. If the vaccination protocol ends at a time when there are still maternal antibodies, this puppy may not be immunized. Apart from this, we have non-responder dogs. There are some dogs that simply lack the right immunological machinery to be able to make a protective immune response to particular antigens. They don't have the right molecules to be able to respond to a parvovirus vaccine, for instance. And they will never be able to do that no matter how many times you vaccinate them. You will only know that you are dealing with a non-responder puppy if you perform antibody testing at least 4 weeks after the primary vaccination series. You can use either a specialized laboratory that performs the gold standard test, that is hemagglutination inhibition or virus neutralization, or you can use in-clinic titer tests. For CPV, there is a strong correlation between the presence of antibodies and protection. So if you test this puppy 4 weeks after the primary vaccination series, and it is seronegative, you may be dealing with a non-responder. You can try another vaccine, another brand, and retest the puppy again, just to be sure this was nothing related to the vaccine. But if it is a non-responder, it's not going to change and he will still be seronegative. Some concern has been raised about the efficacy of the vaccines to protect against different antigenic variants, especially CPV2C. Although the evolution of the virus also raises questions regarding the efficacy of some vaccines and the necessity of updating a vaccine according to new variants circulating, so far there is no evidence for a role of the CPV variants in vaccination failures. Several studies have demonstrated that currently available vaccines, including those prepared with CPV2, confer a good degree of protection against CPV2A, 2B, and 2C. Incorrect vaccine storage can also be a cause of vaccine failure, and sometimes this can happen in your own practice. This study focused on evaluating the CPV variants detected in 123 dogs showing clinical signs of gastroenteritis in Italy from 1994 to 2017. Around a third of the dogs involved had been vaccinated, raising doubts regarding the vaccination protocols or the ability of the vaccine to provide immunity. The problem is that there is no information about the age of the puppies when they received the last dose of CPV vaccine. But in fact, they found no statistical relationship between the vaccination status and the antigenic variants. In those two studies, puppies vaccinated with modified live virus vaccines containing CPV2 or CPV2B were challenged with a 2C isolate and were protected. Before we talk about vaccination protocols, let's discuss a little bit about maternal immunity. Maternally derived antibodies, or MDA, are important to protect puppies in the first weeks of life, but they also interfere with the ability of the neonate to mount its own protective immune response to most core vaccines. Serum MDA prevent vaccine antigens from stimulating an immune response. This is a graphic of an immune response in a puppy for CPV. Let's say that 80 is considered the minimum antibody level to protect the dog against this disease, while 20 is the minimum antibody level that interferes with the vaccination. This means that while the puppy has an antibody level above 20 for this disease, he will not develop an immunological response when vaccinated with most vaccines. Some vaccines may overcome MDA interference before others. When this is the case, in the presence of intermediate MDA titers, not all vaccine viral particles are neutralized by maternal antibodies, and they are able to infect the vaccinated dogs, inducing an active immune response. In most puppies, MDA declined to a level where it is already possible to get a response to a vaccination in about 8 to 12 weeks. However, a small percentage of dogs may still have maternal antibodies above this level around 14 to 16 weeks of age. And that's what's happening in this graphic. During the period when MDA are insufficient to provide complete immunologic protection, but still enough to block the endogenous immune response, known as the window of susceptibility, a puppy can become infected and get ill. It is not possible to predict when this window occurs, as the amount of MDA transferred will vary between litters and within litters for individual neonates. As it is not possible to predict the exact moment of loss of MDA, the initial core vaccination series with modified live virus vaccines usually requires the administration of multiple doses. They are not booster doses. They are applied to trigger a primary immune response as soon as possible after the MDA has dropped. Core vaccination must start at 6 to 8 weeks of age, with subsequent doses given every 2 to 4 weeks until 16 weeks or older. The 2-week interval should be carried out in environments likely to be heavily contaminated, such as shelters. So in this situation here, the vaccine applied at 6 weeks does not elicit an immune response. The same at 10 weeks. But now, at 14 weeks, MDA is below the minimum level that can block an immune response, so the dog starts to produce antibodies. In this other situation, MDA stays above the interfering level until 16 weeks of age. So vaccines given at 6, 10, and 14 weeks of age are not able to elicit an immune response. But in this case, a vaccine given at 16 weeks of age will elicit an immune response. Understand that in the absence of MDA, a single dose of CPV-modified live vaccine provides adequate and robust immunity. So, when we think of a CPV vaccination protocol, like in general, the most important dose is the one administered at 16 weeks or older, when almost all puppies must have already lost MDA, being able to respond to the vaccine. Even with administration of the last dose of vaccine at 16 weeks of age, a really small percentage of puppies may not respond effectively to vaccination because of persisting MDA. Let's give an example. If a puppy starts core vaccination at 6 weeks, has a second dose at 10 weeks, a third dose at 14 weeks, he should receive one more dose at 16 weeks or more. In some countries, we have high titer vaccines and now this novel live recombinant CPV vaccine. Both types are usually combined with distemper virus. Those vaccines can be given as early as 4 weeks of age, and the studies with the live recombinant vaccine have shown that it can protect against Parvo 3 days after administration until 8 weeks of age. So this is another option of protocol. In countries where you have these vaccines available, you can start with one of those vaccines as early as 4 weeks, and then continue the protocol with multiple antigen core vaccines containing canine parvovirus, canine distemper, and adenovirus. After the initial series of core vaccinations, it was recommended to administer another set of core vaccines at 12 months of age. The purpose of this vaccine is not to boost the immune response, but to ensure that the development of a protective immune response in any dog that may not have responded to the primary core vaccines. However, with this protocol, a puppy that fails to respond to any of the core primary vaccinations will be left unprotected until receiving this vaccine at 12 months of age. For this reason, the WSAVA vaccination guidelines group suggests that veterinarians try to reduce this possible period of susceptibility by moving this vaccine from 52 to 26 weeks of age, which is around 6 months. Therefore, the number of primary vaccinations will be determined by the age at which the first vaccination is initiated and the interval selected between vaccinations. An adult dog or a puppy over 6 months of age that was never vaccinated requires only a single dose of core modified live vaccines, Parvo, distemper, and adenovirus, to generate a protective immune response, since they don't have maternal antibodies to block this response. Dogs that responded to vaccination with core vaccines containing modified live virus maintain solid immunity for several years in the absence of any repeat vaccination. So after vaccination at 6 months, subsequent revaccination should be administered at a 3-year interval. There are many studies that have been done that showed that dogs vaccinated with modified live core vaccines are protected for quite long periods of time. This study from Australia, published in 2017, analyzed data from almost 600 cases of apparent CPV vaccination failure. The strain of CPV used in the vaccine was not associated with vaccination failure. However, the age at administration of the last CPV vaccine to a puppy was a significant risk factor for vaccination failure, irrespective of whether the vaccine was marketed for the last puppy vaccine given at 12 weeks. There was a strong negative correlation between the age at last vaccination and vaccination failure. The later a puppy received this last vaccination, the lower the risk of vaccination failure. This is one more study that confirms that the final age for vaccination should be at least 16 weeks for all parvo vaccines, especially in outbreak situations. Finally, this study published in 2022 showed that more than half of the 86 evaluated dogs that recovered from parvoviral enteritis suffered from persistent gastrointestinal signs later in life. Again, this highlights the importance of vaccination against CPV. You can get detailed information on vaccination protocols on the WASAVA website on the Vaccination Guidelines Group page. Thank you very much for taking your time to listen to this presentation, and let's see if there are any questions.
Thank you, Dr. Marcondes, for this excellent informative review, which has highlighted some of the latest insights on canine parvovirosis. We do have some follow-up questions. The first question is, do I need to vaccinate a dog that's already had parvoviral enteritis?
Thank you for this question. In theory, not. A dog that had parvo will likely be protected for the rest of its life. But I have to remind you that the core vaccines usually include parvovirus, adenovirus, and distemper virus, and the dog needs to receive the other components. So even having presented parvo, he needs to be revaccinated against distemper and adenovirus, and will end up receiving the CPV component also.
Thank you, Dr. Marcondes. Indeed, it's important to remember that the recommended core vaccines are not just for parvovirus protection, but also for protection against other important diseases. I have another question concerning parvo vaccination. We have CPV2C in our country. How long does the protection against this variant last if I'm using a CPV2 vaccine?
Well, thank you for this question also. As I mentioned before, there is no evidence that CPV2 vaccines will not protect against CPV2C or any other variant. Protection with CPV-modified live vaccines lasts many years. Some authors talk about 5, 7, 9 years or for life. For sure, adult dogs can be revaccinated every 3 years without any problem using either CPV2 or CPV2B vaccines, even in countries where you have CPV2C variant.
Thank you for this clear response. It's good to know that canine patients are still well protected against parvo with the available vaccines, despite different variants of the virus in the field. Looks like we have time for just one more question. If a puppy becomes infected with parvovirus during their initial vaccination series, do I need to restart the series after he recovers?
Wow, this is a really important question. Regarding CPV, if the puppy had parvo, he is now protected and we don't need to worry about this vaccine. But thinking about distemper and adenovirus, which are the other modified live components of a core vaccine, as I said, the series of core vaccinations are not meant to be boosters. We give them because we don't know the exact time when MDA will decline to a level that does not interfere with the vaccine anymore. So if this puppy has completely recovered from parvo and is able to be vaccinated, you don't need to start the initial vaccination series again. the number of doses that this puppy will still need to receive will depend on its age. For instance, if he's 14 weeks old, he can receive a dose at 14, another at 16 or older, and then another one at 26 weeks of age. But we have to remember that in the absence of MDA, a single dose of modified live vaccine against distemper or adenovirus, as well as Parvo, is enough to immunize a puppy. So we are not talking about how many doses the puppy will receive, but when they will be given. If you are in Latin America and have just vaccines containing parvovirus, distemper virus, adenovirus, parainfluenza, lepto, and bordetella in the same vaccine, you have to remember that for lepto and bordetella, you need to give 2 doses 2 to 4 weeks apart because they are not modified live vaccines. And in this case, the second dose will boost the immunity. So if you had to interrupt the vaccination protocol for more than 4 weeks because of Parvo, I would suggest giving 2 doses of the vaccine, even if this puppy is 16 weeks old, because of these other acute components that need 2 doses to immunize.
Thank you again, Dr. Marcondes, for this informative talk on parvovirosis and for your clear and helpful answers. This brings us now to the close. A quick reminder that your participation certificate for this talk will be emailed after the event, and we look forward to seeing all of you at the next talk. Thank you again for joining, and goodbye.